Hey, it's me, Jen again, and welcome to Save Your Thyroid. Today's guest is not only saving thyroids from surgery, she's also training the physicians of tomorrow at Stanford University. We'll be joined by Dr. Julia Noel after this. Dr. Julia Noel is an assistant professor of otolaryngology, head and neck surgery at Stanford Medicine. And together with her colleague, Dr. Lisa Orloff, they brought thyroid radiofrequency ablation to Stanford. They've been saving thyroids for well over a year now. Today, we'll discuss some of those wins, as well as dispel some common myths about thyroid RFA. Let's get to know Dr. Julia Noel. I was reading that you are an assistant professor of otolaryngology, head and neck surgery at Stanford, which I'm guessing means that in addition to practicing, you're also teaching. Is that right?
That is right. So actually a huge part of the position is to educate medical students, residents, fellows, both just in sort of general knowledge of otolaryngology and kind of my area of thyroid and parathyroid surgery, also help guide residents and fellows through the process of learning to become surgeons and doctors of their own.
By chance, are you getting to train them at all in RFA, or is that something that they kind of have to decide to do on their own later on?
They do get to observe cases when we do them. If it's something that they decide that they'd like to pursue after their careers, then there are opportunities for other education, that could be more hands-on afterward. They do at least have the benefit of getting to observe just how it's done and how to set up the room and what it looks like. So I think they enjoy it.
That is a very cool opportunity for those new doctors to be getting exposed to such a paradigm shift early on in their training, I'm sure. Could you tell me a little bit about how RFA kind of came to Stanford and your experiences with Dr. Orloff?
Yeah, absolutely. And really, so much of the credit goes to her. I think she was really the one that recognized this as something that could be, paradigm changing, as you said, and that it was really important to bring to Stanford as early as possible. I trained with her when I was going through the educational process and then was really fortunate to be able to stay on with her as a colleague. We both sought out training to learn how to do this ourselves and kind of incorporated into the ultrasonography that we'd already been doing a lot of. At any big institution, there's always going to be a lot of negotiation and hoops and red tape. And so we kind of navigated through that over the course of a few months. Really fortunate to finally bring this to Stanford. I guess it'll be 2 years ago in January.
Wow. Yes, that is a common thing that I hear, that it is way easier for a private practice physician to bring on RFA in their practice than it is for those of you who are in these larger institutions. And so kudos to you and Dr. Orloff in being able to navigate that process and be successful in bringing this to Stanford. That is quite an achievement.
Thank you.
Let's talk about a little bit. I was reading an article from August of 2020 about a patient, actually, I believe it was Dr. Orloff's first patient, Sarah O'Brien, who was actually one of the first patients in our Facebook group to be treated with RFA.
Wow, that's excellent.
It was so neat to read that article because I knew her before this whole process started. And so just reading that article, kind of going back and telling her story and then highlighting the success of her treatment was such an exciting and validating thing to see that she's had such a success. And I saw in that article that you were actually assisting in that procedure. I thought it would be interesting if we could talk a little bit about, is her story similar to many of the patients that seek out RFA, seeking this for the treatment of their hot nodules that are just really suffering from the symptoms of hyperthyroidism?
Yeah, absolutely. And I'd say it's still less common than the patients who come and just have large benign nodules that are not functioning. For the patients that do have hot nodules and they've been presented with the option of having surgery or the option of having radioactive iodine, staying on a daily medication that may or may not give them side effects at some point, it feels like the least of three evils. It's not an easy decision oftentimes because patients understandably say, well, I don't want to do any of those things. This has really filled a space for those patients who could either come off of their medication entirely or maybe avoid getting on medication in the first place, or, even have a dose adjustment, dose reduction is some progress in making them feel better. So there have been a number of patients who have sought treatment for hot nodules, in addition to the non-functional ones.
You would say then the majority of them have the compressive larger nodules that are causing them to have symptoms of swallowing difficulties and breathing difficulties primarily?
Yes, that's definitely the majority. And I think those are the patients for whom you can be really confident in saying, okay, we can do this treatment and I know you're going to feel better. Hopefully, even with one treatment, you'll be happy. But of course, there's always opportunity to go further and do additional ones if, you're not quite there, or, there's still significant nodule that remains. And it is, I think, a little more of a discussion to have with the patients who come with hot nodules. A lot of the data that we have, admittedly, is not great for RFA in this specific circumstance. But I think, as long as it's a two-sided conversation and the physician is really honest and upfront about expectations, the patient understands. I always tell patients, I can't tell you for sure if you're going to come entirely off of your medication, but at least we're not going to burn any bridges. We can see if this works, see if you're happy. If you're not, we can do it again. Or, you can certainly say, all right, I'm fed up with it and I'm going to try a different way.
I love that analogy. Burning bridges is a very good description. There's really no coming back from surgery or from radioactive iodine. Once you've gone down that road, that's it.
Yeah, it feels so final, and it really is. And that's why I think for those patients who we anticipate, maybe it's not just going to be one treatment, you're going to be totally fixed. Maybe there will be a second in the course of your whole treatment process, and it might be a little bit more of an incremental process. But I think if patients are willing to do that, then they can avoid the finality of, what it means to go to surgery or what it means to have radioactive iodine.
That's absolutely been consistent with what I've witnessed in our Facebook group and also with my own personal journey down this road. I had to have 2 procedures done due to the sheer size of my nodule, and also due to the fact part of it was extending below my collarbone. It was worth it to me to be able to keep my thyroid intact. And I can say that our group has about 2,700 people in it now. So I've seen quite a few people who say that they feel the same, that they're just so thrilled that we have an alternative available to us now. Let's talk about, what is the setup like for you at Stanford? Are you doing this more in an office setting or is it in the hospital?
We're doing it more in an office setting. We're really fortunate to have very nice equipment and ultrasound machines that are a part of patient visits, even independent from conducting RFA procedures. Patients are awake for the procedure. We check in with them frequently just to see how they're feeling, make sure there aren't really any immediate complications that are developing that we might need to intervene on. Also, just for our own knowledge to know, what patients are feeling as they're having these procedures, in case there's something that we could modify as we continue doing this to make it more comfortable or less anxiety provoking. It's worked out really well to have this be an office-based procedure. And we can avoid kind of the whole, rigmarole, you could call it, of the operating room setting.
Oh, I'm sure that it makes the costs lower. I'm sure it helps with anxiety with patients and just keeps everything more simple.
Yeah, absolutely. All the above.
Let's talk a little bit about the types of nodules that you're treating as far as the sizes. What are the common characteristics for patients who are kind of just starting to learn about this procedure?
Yeah, that's a great question. And really the ideal patient is someone who has a thyroid nodule that has been biopsied a couple times and has been shown to be benign. And there are certain features that we as physicians are looking for on their ultrasound to kind of help tell us if this is more likely to be a benign nodule. Composition makes a difference. So patients will probably hear these words solid or cystic when others are talking about what their thyroid nodule looks like. That just helps me and us decide if maybe radiofrequency ablation will be your main treatment, or if there might be another component of like an alcohol ablation, which is a chemical ablation, which tends to be a little bit better for the cystic part. And size, I think, is sort of the $1,000,000 question in a lot of ways. And that is where some of the discussion comes from. When nodules are a little smaller, maybe 3 centimeters, 4 centimeters, I think it's very reasonable to anticipate that one treatment will be enough to resolve any external abnormality that's obvious or difficulties with swallowing, breathing, kind of that pressure or choking sensation. As the nodule gets larger than that, it's really more a matter of, can we get away with one, or is this someone who might need a second treatment? We try to be upfront about that ahead of time, just to make sure that, that patients are making the right decisions for themselves.
And what about any other applications? We're hearing more about thyroid cancer and other applications for RFA. Are you seeing anything that's indicating that we might be heading in that direction?
I do think we're heading in the direction of starting to treat small thyroid cancers with RFA. There's a lot of great data that's coming internationally that shows that, a single RFA treatment can really drastically reduce the size of these small thyroid cancers. We call them papillary microcarcinomas because they tend to be a centimeter or less in size. We will certainly, I'm sure, start doing that in the US in the near future. I think that'll end up being a really good, again, sort of therapeutic option for patients who are in the position of having these small thyroid cancers, not wanting to commit to surgery and the possibility of taking thyroid hormone, but also not wanting to pursue what we call an active surveillance route, which generally means that you're getting, ultrasounds on a regular basis and seeing if anything has changed to help decide if you can keep doing that or if it's time to intervene in some way.
Is a question that we are seeing a lot in the Facebook group. Is patients really want to know when that's going to become more common. Currently, there's only a handful of physicians that I know regularly treat those patients. And then, of course, patients sometimes go overseas to have that done. But it's exciting to know thyroid cancer patients are going to have potentially as an option to preserve their function. What about insurance and Medicare? That's another big question in the group. Are you guys having any success with that, with RFA being covered by Medicare or insurance?
We have, and I have to say it's been getting better in recent months. Medicare especially has been pretty good about recognizing this as a valuable procedure that can really save them as an insurance company a lot of money in the long run as an alternative treatment. There are other insurance companies that have been coming around probably now as a result of me sending a number of appeal letters on patients' behalf.
Good for you.
To educate them about this procedure. Then the next time around it becomes slightly less of a battle.
That is excellent. I'm so happy to hear that. We keep encouraging patients to not give up. Very encouraging when we see patients that are successful. Some of them have to appeal 2 or 3 times, but it's just the validation of knowing the insurance companies are seeing the benefit, aside from the financial burden being relieved, because that is such an obstacle for so many patients to not be able to afford the out-of-pocket cost. So I'm really hopeful, especially with Medicare, because of the large number of patients who are on Medicare, statistically speaking, who would have thyroid nodules. It just seems logical to have that be covered by Medicare.
Totally. And I think it's totally unfair that it is such an access issue right now because of the lack of consistent coverage. And certainly on a national level, we are working on this to, create changes to make sure that it does become a covered procedure in the future. And sometimes I will be very candid with patients who maybe, have a nodule that's on the smaller size that is a little bit less symptomatic, that if that is really the deciding factor between you choosing this versus choosing surgery, but you really want to do RFA, maybe wait a year or two and see if this does become a covered procedure. I would hate for you to have to make a certain decision solely based on finances when you could afford to wait a little longer. Depends on the patient and the circumstances, but I think there are some who can't afford that little bit of extra time.
Those of us who are just like myself, who were getting treated early on after the FDA clearance, we're just so thankful that it's even available.
Yeah.
Any of us would pay anything to save our thyroids.
It is really priceless.
Yes. Are you seeing a shift in the number of surgical cases because of RFA being available now?
It's a good question. I would say not yet, not so significantly that the surgical volume has decreased. But I would say there's been a little bit of a shift in maybe the types of surgeries that are happening, where now if I'm doing surgery, it is more likely to be, say, a thyroid cancer or an indeterminate nodule than it is to be a benign nodule that has just gotten big and is causing problems, in large part because a lot of patients are choosing this alternative option.
So a common thing that we see both from patients and from physicians who are not aware of RFA as a valid treatment option for nodules is myths and misinformation. You can dispel those for those new patients and doctors who might be watching this video. So the first myth is thyroid RFA uses radiation to treat thyroid nodules.
That is a great myth to dispel because it's actually a heat-based ablation. So it is just that the tip of the probe is getting hot and therefore destroying the tissue, but there's no radiation exposure. And actually, same with the ultrasound probe that the physician is using to guide the whole procedure. That is, far and away the greatest thing about ultrasound is that you can see so much with really no radiation exposure, unlike what you would get with a CAT scan or an MRI.
Yes, that's a common thing. We see patients thinking RAI and RFA are the same thing. And so it's very good to clarify that. Okay, what about the myth? Thyroid RFA causes too many side effects, such as scar tissue in the neck that might make a future neck surgery more difficult.
That is also an important myth to dispel because I understand that it might dissuade people from choosing RFA. I have to say that although I personally haven't had any patients on whom I've operated after they've had RFA, I've had plenty of patients, almost all patients that go to the operating room and they have had fine needle biopsies before they've had a surgery. To some degree, absolutely. Any invasive procedure will create scar tissue. The great thing about RFA is that the scar tissue is created where it's less important, if you will. So many of the things that we as surgeons really want to preserve when we're working around the thyroid are the parathyroid glands and your vocal cord nerve. And those, really both are going to be sort of on the back side of the thyroid where radiofrequency ablation probe, will have never gone.
It's interesting. In the 2 years that I've been doing this, I have not encountered a physician yet who has done a surgery on a patient after having had RFA. So
yeah, I think it's really uncommon. And, the only information that I have is sort of word of mouth from colleagues around the world that have had, and again, it's a really small handful of patients who have been in that circumstance. At least what they've said is there's certainly some scar tissue that is encountered maybe when in the first steps of the surgery, similar to when patients have had, again, like a fine needle biopsy beforehand. But where it really counts, there's no scar tissue because the procedure has stopped short of that area intentionally because we want to protect those structures.
What about the myth thyroid RFA causes cancer to spread?
Yeah, and there are a couple studies that have taken biopsies from thyroid nodules after they've been treated with RFA. Unfortunately, for those that went in with benign nodules, we haven't seen any transformation of the cells inside the nodule to anything that looks like a cancer. Patients should certainly be aware that the appearance of their nodule on the ultrasound is going to change afterward. To someone who maybe doesn't know that they had RFA or isn't familiar with what those changes look like, that can certainly raise alarm bells. But we do have the data that says that when we take tissue from the inside, none of it looks like there's any cancer that has formed because of this. And then for those patients that are getting ablations done for maybe small thyroid cancers or for recurrent nodules, somewhere in the neck. You're right. We don't have many, many years of data as we do with the benign nodules, but we're now getting, 5-year follow-up or 7-year follow-up from these places internationally that have been doing this for such a long time. So far, it's really promising and doesn't show that there's any more spread from doing the RFA than, say, if a patient had elected to have surgery or even had elected just to watch up front.
That's a really good point you made about how nodules look so different after RFA to an untrained eye. I've had myself and several other patients mention that they went to their local physician for follow-up after RFA, and their physician was just terrified that something horrible had happened.
Yeah.
And how the patients over there saying, no, I promise it's not cancer, it's the RFA. But that's definitely a myth that we want to dispel for the physicians. And then as far as the cancer spread goes after RFA, I had one physician tell me, think about, can you bring back the dead? No. Killed it, so you can't really bring back the dead. So I thought that was a funny way of explaining it.
That's a great way of putting it. Yeah.
Okay, well, what about the myth that thyroid RFA is only for cold nodules? We've talked about this a little bit already.
That is, of course, what everyone will hear is sort of the ideal patient, because we know that there will be pretty reliable size reduction. It'll be significant. Oftentimes with just one treatment will resolve a lot of the symptoms that the patient had come in with. Then hot nodules, they just take a little more thought, I think, before offering this as a treatment. There's the consideration of how much medication is the patient taking. Perhaps their numbers are sort of borderline and they haven't yet been started on medication. I certainly don't want patients to think that they can't have their hot nodules treated with RFA, because they certainly can. You as the patient want to make sure that you are on the same page as your physician in terms of what hopes and expectations you're going into the procedure with and what the physician feels like they can realistically deliver on with doing this procedure. I think people that are going in with maybe higher doses of medication or really big nodules that are hot, they may be the ones where, okay, one treatment is less likely to totally solve the hyperthyroidism. But if someone's got a smaller nodule, or maybe they're sort of in the pre-hyperthyroid phase where their numbers are borderline and they haven't yet started medication, but their endocrinologist has said, maybe think about starting some medication sometime soon. Maybe those are the patients, kind of take them off the edge, so to speak.
I don't know as much about hot nodules and how they work because that wasn't my personal experience. But one thing I could kind of relate somewhat to someone with a larger hot nodule that's already on a high dose of medication, that when I was first reading about RFA, the data says that when you have a larger nodule, the reduction won't be as dramatic as it is when you have a smaller nodule. And I remember just thinking to myself, well, gosh, if my nodule shrank by half, I would be thrilled.
Yeah.
And at this point, my nodule has shrunk 90%. So I have had
incredible,
quite a successful outcome. But I can say probably for someone who's on a high dose of anti-thyroid medication, even just to be able to reduce their medication might be something that they would be very happy about.
Definitely. And so that's why I do still think it's worthwhile offering it and having the conversation, because that is worthwhile to the patient. Then that's certainly something that can be realistically accomplished by doing this procedure.
Great. Okay. Well, one last myth. Let's talk about, and this is a concern that a lot of patients have, is that RFA causes vocal damage.
I am so glad that we're talking about this, because that is obviously a primary concern about having surgery. The risk of a vocal cord nerve injury, temporary or permanent, typically in the single digits, maybe 5%, 7%. Thankfully, we've seen RFA to be at lower risk of causing a vocal cord nerve injury than surgery. I think that's for one primary reason, which is that when you're doing this procedure as the physician, you can see exactly what you're doing and where you are the entire time. This is all done under ultrasound guidance. We are very careful to avoid the area where the vocal cord nerve might be, even though we don't explicitly see it on an ultrasound. The other advantage, having a patient be awake during the procedure is that if there's any change in real time that we can assess, oftentimes we can do something about it at the time, hopefully make it go away or at least recover faster than it might otherwise.
Yes, we have, in our group of 2,700 patients, we have seen, I think, one patient, I believe, lasted longer than 3 months. And then we've had 2 others who've had voice changes that resolved after a few weeks. Other than that, anyone who has had voice changes, theirs have resolved very quickly. We've talked about how the swelling and the compression that could occur after RFA could be compressing those vocal nerves. And there's been a few times where a patient would say, well, I had no problems until the next day. And so we talk about, well, you've got some swelling now, give it some time and see if your voice doesn't return. And nearly all of the time they say, yeah, it was the next day. I was much better. So someone who's an ENT, you can probably speak to this, how sensitive all of this is, your ears, nose, and throat being so closely related. Those sensations can be felt in all of this area.
So that's such a great point about the other structures that are contributing to the voice. We do spend a lot of time talking about the vocal cord nerve, but in reality, there are whole muscle groups that are laying on top of the thyroid gland that are involved in talking and swallowing. Those getting sort of pushed on by the nodule as it's swelling after the procedure. Those muscles get a little bit bruised just because that's where the probe has to go in and out. There can certainly be some temporary changes that patients may notice just depending on, how aware they are of their own voice change. Like you said, these go away in a day or two and then sort of back to normal.
Well, thank you for dispelling all of those myths for us. Is there anything you would like to mention just about your experience with RFA or how patients can reach you? Any last comments that you have?
Yes, absolutely. I'm really passionate about this procedure. I think as it becomes more widely known and widely available, I think it'll be how we treat most benign thyroid nodules and probably some small thyroid cancers as well. There will be a lot of changes in insurance coverage that we see in the next couple of years as this is recognized to be, not only better for the patient's health outcome, but also more financial sense for the insurance companies. I'm always happy to see and talk with any patients about RFA. I'll talk their ear off about it and give them lots of pamphlets to read. We have what I hope is an informative website about radiofrequency ablation through the Stanford website, and that's got our clinic contact information there.
Yes, and if you have patients that are looking for more information and need support, feel free to point them towards our Facebook group. We're always just trying to provide unbiased education for patients. We don't promote anybody. We just say, here's the information. Now you learn it, and then you decide what you want to pursue and educate yourself so that you can make the most informed choice possible. And let us know if we can do anything to help support you and Dr. Orloff and Stanford as you're doing this, because we're just so excited anytime we learn about a new provider. Now that there's, I believe, 70 in the US, we just hope that number just keeps on growing.
I really hope that this just becomes a more accessible procedure for everyone.
Okay, y'all, I'm gonna get real up close and personal and tell y'all something. Okay, maybe not that close. I know that most of y'all who watch these videos are not subscribed to this channel, and I get it. Sometimes you're busy and you don't have time, but anyway, I really, really would appreciate it if you could subscribe. Now, I know you're thinking, oh, she just wants more views, and yeah, kind of, but still, the more of you who subscribe and like these videos, the more that the stinking YouTube algorithm is going to put them in front of the people who need to see them. And I mean, how are people going to see it if you don't do that? Half of the people walking around everywhere on this earth have thyroid nodules, and they need to know this stuff. So go ahead, click that button, do it right now. You can pause the video if you like. And if you can think of somebody like off the top of your head who needs to know this information, then share it with them and make the world a better place. So if you could do that, I'd really appreciate it. Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.